I'm going to zoom my screen. Just tell me if that seems comfortable size. So as you've seen, a lot of questions keep getting asked in exam related to multidisciplinary approach, especially for the cases where you're going to residential houses, old age care homes, where there are patients with some medical history like dementia or some other medical conditions. And the questions keep getting asked on their management as well. So I'm sure everyone's aware and seen questions like that, right? So we are going to approach those questions through this article. And what are the oral manifestations that you can expect in those patients? What are those patients? And how will you manage them? What would be the health promotion advices that you would give them? So ADC exam is really huge on health promotion questions. Almost every SBQ would have a component which would have a promotion question, or how would you manage the condition, prevent the condition, or the palliative care instead of the invasive management. There are questions on invasive management, but mostly the palliative care and the health promotion care is taking the front seat in the ADC exam. So I'm sure everyone's aware of that approach for the ADC exam. Before we proceed, right? So you know what we are addressing here, and we can prepare accordingly. So I'll start with this. So oral health of medically compromised patients who are nil by mouth, who are on maybe feeding tubes, who have recently undergone chemotherapy, radiotherapy, and they require palliative care. So what is the management or the instructions or guidelines or protocol for the dentist to manage such patients? The Zoom size is enough for everybody to read. It's comfortable size. Yes, okay, perfect. So oral care is pivotal in maintaining the oral health, particularly because the oral diseases are mostly preventable by adhering to good basic oral care practices, right? So basically, you know that even in these multidisciplinary questions where you keep getting asked, you need to identify your therapeutic guidelines, cover these manifestations and management. This is a step beyond that for some complex options that you may get and some close options that you may get, and how to approach those. So what are the various conditions and systemic conditions which can make patients medically compromised and which can require the dental management? So there is type 2 diabetes, the cardiovascular diseases, respiratory conditions, adverse pregnancy outcomes. They are some of the main general health conditions which are associated with poor oral health, predominantly uncontrolled periodontal disease. If everyone remembers and has seen in exam the questions about preeclampsia, gestational diabetes and gestational hypertension, these questions are taking the front seat, and almost every history of the patient is now associated with some underlying systemic condition as well. Some of them can be medically compromised, but some of them can be medically afflicted, right? In today's article, we are more focusing on the ones who are compromised, right? Certain group of patients who are not just medically afflicted or have a systemic condition, but rather they are compromised by some maybe not consuming food by mouth, so nil by mouth, that is NBM, or those who are on feeding tubes, those who are undergoing chemotherapy or radiotherapy, those who are in palliative care, right? And they are more likely to develop oral complications like xerostomia and oral mucositis. Consequently, these three patient groups are at the highest, greatest risk for further deterioration of their oral health. In addition, these oral complications can lead to long-term secondary complications like malnutrition, aspiration pneumonia among such patients. So what happens is When the oral conditions and oral manifestations become severe and are not managed timely, they can further deteriorate the patient's capacity to consume food and thus leading to severe malnutrition. And in turn, the infection can also get aspirated, spread to the lungs, and lead to the aspirational pneumonia. So these are the severe life-threatening complications that can arise. That is why even in these bedridden patients or patients after chemo and radiotherapy, when they're severely medically compromised, the oral management has to take the front seat to prevent the serious life-threatening medical complications. So let's discuss the category of individual conditions here first, and then we will move on to the oral manifestations and then progressing to how to manage them. So first category of patient is patients who are nil by mouth. These patients are restricted from eating and drinking due to the range of medical conditions. Could be dysphagia, unconsciousness, compromised consciousness, or probably some surgeries that has made their bowels difficult to manage their eating through the mouth. So the following oral complications are common among them, mainly due to the dehydration, after effects of anesthetic agents, as well as fear and anxiety associated with having surgery in patients undergoing surgical procedures. So what are the manifestations that you would observe in such patients? And see, in the exam, all these articles that we cover in our course also, we go beyond and we do some paid ADJ articles, Australian Dental Journal articles, for all the new SBQs that might come in the exam. So every time we know in ADC, the ADC is throwing some 20 to 30% new SBQs each time. Although 60 to 70% of the SBQs are coming repeat, which we have in our database, like we have created our entire 5,000 question file, the database. Out of that, 60 to 70% gets repeated in the exam. But in my course, the main job is to also prepare for the rest 30%. The competition is getting higher, and definitely the cutoffs for the exam are getting higher. The number of the candidates who are passing the exam is getting lower. So the best bet to prepare and clear the exam is by preparing the most, by being prepared 200%. And that's actually what we do with the course. We add the 30% preparation by preparing and going ahead and doing the Australian Dental Journal articles of management of even more complicated conditions. So this article would be in that category, like a new SBQ coming up where the patient is medically compromised and you are asked as the dentist to observe, find, diagnose, and then manage those manifestations. So you should know that these conditions are familiar to you, but in these patients, what to expect. So xerostomia, thicker saliva, dry and cracked lips, difficulty in swallowing and speaking, halitosis, difficulty in wearing dentures. These could be the common oral implications that you would observe in such patients. Now, patients who are on feeding tubes, so absence of intaking any nutrition from oral route in these patients can lead to the alterations in the biochemical composition of saliva, right? It can disrupt the flow rate. It can disrupt even the normal oral microbial flora, right? We know candidiasis, the most opportunistic infection of the mouth. The moment the microbial flora in the mouth alters, it overtakes, right? And we know in therapeutic guidelines as well, we've done the variations of candidiasis found in the mouth. And it becomes even more complicated if the patient is denture wearing. So again, even in the feeding, non-feeding patients who are on the feeding tubes, you would find research suggests they would find xerostomia, thicker saliva again, oral infections like candidiasis, and difficulty in swallowing and oral ulceration. The muscle atrophy also sets in that makes the difficulty in swallowing and dysphagia even more prominent in such patients, right? So research suggests that the natural oral feeding is a protective mechanism against the colonization of the oral cavity with pathogenic bacteria. So you could have an SBQ on a patient who's on feeding tube. You may have been called in hospital to observe them or to manage them palliatively, or maybe a patient who's on residential care with certain specifications, and you would be asked to actually promote health and suggest. And the question could entirely be like, why do you think the patient has dysphagia or difficulty in swallowing or such conditions? And you could be given various options which would make sense to you, right? But the correct logic of those we should know. And the correct concept only comes through certain guideline articles, these scientific articles released by Australian colleges or Australian Dental Journal. So the function is that the reason actually becomes is the oral feeding mechanism is a protective mechanism against the colonization of the oral cavity with the pathogenic bacteria. Accordingly, when the absence of oral feeding is seen alongside the above mentioned oral complications, it can lead to overgrowth of pathogenic gram-negative bacteria as well. So it's the gram-negative bacteria that can actually travel to the lungs through aspiration, through saliva, and lead to the aspirational pneumonia. Usually end-stage patients acquire that. Now, the other category of the patient is the patients on chemotherapy, radiotherapy, and those who are in the palliative care, right? So far, the categories, first two categories are making sense for everyone. The NBM, who are totally not feeding by mouth, and those who are on feeding tubes, right? The third category is the patient who has taken or being taken the chemotherapy and radiotherapy, right? And now in the palliative care. So now those patients, those who have seen the chemotherapy and radiotherapy, they have taken doses in higher amount, and definitely it has altered their oral environment in terms of the microbial, in terms of their tissue turnover. We've seen oral tissue changes also in such patients. So they present with oral mucositis. That is the number one presentation after the chemotherapy and the radiotherapy, right? Then the xerostomia, right? Oral infections, including candidiasis, and because of the compromised integrity of the mucosa, you will also see the viral and the bacterial infections. Salivary gland dysfunction, including sialadenitis, and that's the reason the deterioration of the salivary gland leads to the xerostomia. Reduced salivary flow, even the quantity as well as the quality of saliva subsides. Then it also affects the taste buds, and it leads to taste dysfunction, including dysgeusia and ageusia, right? Which is altered taste or absent taste. So in addition, patients who are on radiotherapy, they can develop osteoradionecrosis. So associated with radiation is known as osteoradionecrosis. Do not confuse it with MRONJ, which is your medicine-induced osteonecrosis of the jaw, right? Medication-related osteonecrosis of jaw is MRONJ, right? And then is your ORN, which is osteoradionecrosis. Both may have similar clinical presentation, but the etiology, underlying etiology is entirely different. So osteoradionecrosis of jaw leads to poor healing of the bones. Now, these are the three conditions which you may be called for, and you may be called to observe, diagnose, and manage in your patients. Now, let's talk about the individual manifestations that you would be finding them, right? What are the likely causes? What would be the clinical features that you would observe, clinical presentation, and what should be the management then? All right. So now coming to xerostomia, the subjective perception of dry mouth, which is not necessarily accompanied by hyposalivation or a reduced salivary flow rate, is known as xerostomia, right? So it is mostly a subjective feeling. It could actually be a true dry mouth by reduced flow, or it could be a perceived sensation, right? On the other hand, a significant reduction in stimulated or unstimulated whole salivary flow rate is defined as the salivary gland hypofunction. So when it really affects the growth, the quantity, it is actually reduced hypofunction. It would be reported as xerostomia. Patient would complain of dry mouth. Therefore, it is important for the practitioners to distinguish between the xerostomia and significant salivary gland hypofunction. Xerostomia is most frequently cited as a side effect of using a range of medications. So it is a temporary reduction in the salivary flow. And where the salivary gland itself is affected, right? That is salivary gland hypofunction. So all the drugs, they only transiently lead to the reduced salivary flow. Am I correct when I say that? You agree with that, right? It is not a permanent effect in most cases. Yes? We all understand that, right? So far, the SGH, salivary gland hypofunction, would be an inherent changes to the salivary gland, whereas the xerostomia caused by the drugs would be a transient effect on the flow of the saliva, right? The gland itself is not hypofunctioning, right? Now, xerostomia is most frequently cited as a side effect of the range of drugs. For example, most likely associated are antidepressants, antihistamines, antihypertensives, and anti-asthmatic agents. Radiotherapy to the head and neck region, Sjogren's syndrome, other systemic conditions, including diabetes, hypertension, and asthma, and dehydration and chemotherapy, they all also have been suggested as the other common causes of xerostomia, right? So Sjogren's, we know, is an autoimmune condition against your salivary glands, right? Then diabetes also naturally causes dehydration as well as dry mouth, hypertension, asthma, and they are even the drugs associated with them are linked with the xerostomia. Even the conditions are linked with the xerostomia, right? So it's like a irony here. The condition and the drugs both lead to xerostomia. Then chemotherapy is also associated with it. Now, what are the clinical presentations? So clinical presentation would be thick and stringy saliva, then a dryness and crusting and cracking of lip because saliva provides a natural lubrication to the tissues, atrophy and fissuring of the tongue, fragile oral mucosa, which is more likely to break and bleed, difficulty in speech, eating, chewing, and swallowing. Then other conditions that you can find with xerostomia is oral burning sensation, pain, and sensitivity to the spicy food, difficulty in wearing dentures, taste disturbances, increased thirst as well, right? Because of the natural dryness here, the patient would feel more thirsty, the taste would be altered, difficult to wear dentures again because saliva also acts as a natural lubricant while the denture is worn. So these are the clinical appearances. As you know, ADC can give you, without mentioning in history, pictures of the lips, picture of the tongue, picture of the oral cavity now. So you've seen many SBQs now without clearly mentioned in the history, the chief complaint and all. They give you the picture and ask you what is the abnormal finding that you find on it. Have you noticed such questions as well? Like you get the clinical picture and the next question, without mentioning anything from the patient's history in text or words, a clear picture and a direct implication of a question. What is the abnormal finding that you see? And the pictures are not as high res or clear as you can see in these articles. But the more you practice, the more you look at those pictures and oral manifestations, the better your chances to land successfully and make the correct diagnosis in the exam. So this is the fissuring of the tongue, again, caused by your xerostomia. The other clinical manifestation is oral mucositis. Let's see what are the features presented with that. So it is defined as inflammation of oral mucosa, which is characterized by erythema or ulcerations. And as a consequence of chemotherapy or radiotherapy, it is referred to as oral mucositis. It is one of the most ubiquitous and complex complications in patients who are undergoing cancer therapy and palliative care. So there are various stages in the development of oral mucositis also, right? In the exam, you can get a question actually where the clinical situation would be defined, and it could be a new question for sure, asking for the classification of oral mucositis, right? So in this class, we are also going to talk about the classification on the staging of oral mucositis. So there are several stages in the development of oral mucositis. It starts with initiation, then ulceration, and then there's also a phase of spontaneous healing. Yes. So remember that there is also a spontaneous healing going on in the oral mucositis situation. So onset of oral mucositis can occur following 1 to 2 weeks of chemotherapy or radiotherapy. And spontaneous healing could happen 2 to 4 weeks after cessation of chemotherapy and radiotherapy. So remember this is a very important and could be directly asked as question. If I ask you, what is the resolution time of the oral mucositis after the cessation of the therapy? And the various options are given, 1 to 2 weeks, 2 to 3 weeks, 4 to 6 weeks, and 2 to 4 weeks, then you know the answer, right? Everyone, if this gets asked as a question, would you be able to answer it correctly? Can I really assume that? Would you be able to answer it absolutely correctly? Perfect. Now, clinical presentation. So depending upon the severity, and we are going to talk about the stages now, a patient with oral mucositis can present with a range of clinical features, which can include, but of course there can be more, starts with redness, erythema, erythematous lesions, burning mucosal discomfort. So that's why when you get the burning mouth syndrome patients, taking more history is important. Everyone knows that the burning mouth syndrome is a diagnosis of exclusion. Is that correct? You have so many SBQs on BMS getting asked now. Very hot topic, right? Xerostomia, oral mucositis, oral candidiasis. There is no way ADC is going to miss on these concepts and questions. Is everyone with me on that? By no ways you're going to miss out on these concepts, right? So that is the reason in the course also we make sure just don't do what the questions are asked in the past. You have to prepare for the 30% which doesn't get asked. And these are the articles, these are the topics that prepare you for that, right? So burning mucosal discomfort, if you ask the patient the history, what history, that is there a chemotherapy, radiotherapy history, then you exclude the BMS, which is totally the diagnosis of exclusion, that it should not be coming from any other systemic cause, right? Or any other medical cause or drug related cause. Then pain and soreness, ulceration and bleeding from ulcers, and even deep submucosal ulcers, they would be found in oral mucositis. It would ultimately lead to difficulty in eating, chewing, and swallowing. It's understandable, right? And also difficulty in wearing dentures. So can you see the red patch and the alteration in the mucosa, the breakdown, the ulceration here under the circle? Can you all appreciate that? If a picture similar to this is given to you and the history of chemo and radio is given to you, would you be able to mark the diagnosis as oral mucositis or no? Yes or no, please? Yes, absolutely. So radiotherapy induced erythematous lesions in the right buccal mucosa, right? This is induced by the radiotherapy. Now let's look at the WHO classification. It's a very simple classification. And now, have you noticed ADC is asking the grading, the staging, the stability, the instability. It's going technical in so many questions. Have you seen, have you noticed, if you've been following the past questions, we have it covered in our advanced file also. You've seen that question, right? Have we seen in the perio classification, it's going beyond asking the stability, instability, then it's going for your even erosive wear, the staging, and we have been doing that in the live classes also. Then it's also going and asking about the BPE scorings. So all the scorings and the criterias and the grades and the perio staging and grading, everything, the technical classifications are getting asked. So even for oral mucositis, be prepared for that. Grade 0 to grade 4. 0 is no oral mucositis. 1 is just erythema and soreness. So the superficial surface involved redness. Grade 2, the superficial surface got broken and ulcer happened, but they're still able to have function. So ulcer with function. Grade 3, ulcers are there, but they probably are so deep it hurts and they require liquid diet. The function is lost. Is that correct? Then grade 4, ulcers are there, alimentation not possible, right? Even the liquid diet is not possible. Coming for oral candidiasis now. So grade 0 to grade 4, understood by everyone? Grade 0, no oral mucositis. Grade 1, superficial erythema, soreness. Then grade 2, there is an ulceration of the tissue, but they are still retaining the function to eat. And then grade 3, where there is ulceration, but they're not able to eat and function, but only take the liquid diet. And grade 4 is the most severe, where ulcers are so deep and severe, the patient cannot take anything orally. So NBM, right? Basically. Then oral candidiasis. It's a common fungal organism in the oral cavity which cohabits with the normal oral flora in a vast majority of individuals and does not cause an infection under normal circumstances. Nonetheless, the below alterations to the oral and systemic environment could lead to excessive growth of this organism, leading to opportunistic infections like oral candidiasis. So, if there is a loss of equilibrium in oral flora after antibiotic treatment, that can lead to candidiasis. If there is an immune suppression due to drugs or disease, what drugs here anyone can mention can lead to immune suppression? Anyone here? Long-term therapy of which drugs lead to immune suppression? Yes. So the systemic steroid therapy for any condition can lead to immune suppression. Hyposalivation caused by drugs, disease, or radiotherapy also will lead to candidiasis infection. Damage to the localized tissues, mucositis after radiotherapy or chemotherapy can lead to candidiasis. So xerostomia and mucositis that we just read above can actually have this third manifestation on top of it, the candidiasis. So what are the clinical presentations of oral candidiasis? There could be variations. One is the pseudomembranous candidiasis, oral thrush, right? That is white plaque, which is scrapable. Under the blue circle, can you see on my screen here? Everyone can appreciate the white plaque, the oral thrush, the pseudomembranous candidiasis of tongue. And then the second variety is the erythematous candidiasis. The erythematous candidiasis is a red denuded patch and it can lead to burning sensation, red inflamed oral mucosa, bald and red appearance of the dorsum of the tongue, so denuded appearance. There would be loss of filiform papilla, and it would on top of that lead to discomfort and taste changes. Although it's rare, but oral candidiasis can also present as angular cheilitis in medically compromised patients as well. We know the two areas where the angular cheilitis are more commonly seen. In the medically compromised patients, angular cheilitis due to candidiasis is a rare manifestation. But the common manifestation or a common likelihood to see angular cheilitis, two conditions can anyone mention here? Lower vertical dimension of the dentures, absolutely correct. The video afflicted and the nutritional deficiencies, iron, folate, B12. Absolutely correct, Bhumi, right? So there are two causes, either nutritional or the denture trouble and the saliva accumulation on the corners and the edges, right? So these are the two likely situations where it is more commonly presented. But would you now remember the third rare but a likely condition where angular cheilitis may also present? Yes, in the medically compromised patients, the NBM patients, feeding by tube patients, or chemo and the radiotherapy in the palliative care patients. Would you remember the third condition now? So anything new comes in exam with these questions, with these concepts, are you feeling confident that you will be able to answer those now? Now, oral care of medically compromised patients. You did the conditions, you did what are the medical situations where you're finding oral manifestations. Now you learned what are the oral manifestations, most common ones, the mucositis, the xerostomia, and the candidiasis. The third aspect of this lecture is the management part, right? Is everyone with me? So far, so good. Everything coming along, making sense, and a coherent way of understanding and learning the concepts? Perfect. Let's move along and now towards the last leg of the lecture, which is the management, the advices, the therapies that you could do for them. Some of these patients, including those who are very sick and lack the energy to clean their teeth and cannot grip a toothbrush properly, are unable to perform self-oral care and hence may require assistance from a carer. In general, the guidelines below can be followed to perform oral care in these patients. Does that sound familiar in a lot of SBQs where the carers are involved now, where they are in the residential homes, dexterity is low? Does that sound familiar and a condition that ADC is keen on asking these days? Does it sound like that? Yes, right? So let's see what we got to do. Oral hygiene practices use a small-headed and a soft bristled toothbrush. Have you seen questions where the questions are actually getting asked? The power toothbrush, the electric toothbrush, the soft bristle toothbrush, twice a daily, once a daily, fluoride toothpaste, non-fluoride toothpaste, all these options coming along, varnishes, right? Absolutely correct. We have seen such complicated options and confusing options, but we should know sure short how to manage them. So first, a small-headed and a soft bristle toothbrush to clean the teeth and gums twice a daily, fluoride toothpaste, pea-sized toothpaste for patients without dysphagia, coming to the doubts in a while, and a smear of a non or low foaming toothpaste is preferred for patients with dysphagia. So those who have difficulty in swallowing, would you remember this, right? Would you please remember this? Is a very key concept. If in the history it's given patient has dysphagia, difficulty in swallowing, use a non-foaming or a low-foaming toothpaste. Very good takeaway point. Would you remember that? Now, a piece of gauze or oral swab can be used to remove the debris in patients with poor oral control, damaged gums, or those who are unable to rinse. To maximize the effect of fluoride, patients are encouraged to spit the toothpaste out, but not to rinse, right? So when you're such high-risk patients, you can actually ask them to spit it, but don't have to rinse it. Why not to rinse it? To have a prolonged effect of fluoride on the teeth and further strengthen it. Am I correct when I say that? Spit but don't rinse to have a long-lasting effect of fluoride. Can anyone here tell me how long the fluoride remains active when topically applied? How long the reaction takes place? Anyone knows that? If the ADC gives you options, 1 hour, 12 hours, 4 hours, 8 hours. What's the closest answer to how long? So fluoride remains 3 to 4 hours active post-application. All right. 3 to 4 hours, the fluoride remains active for uptake by the enamel. After that, it becomes unavailable. A powered toothbrush may be recommended for patients with a manual dexterity issues. Now, the question got answered for the above question. When the carer is doing it and the carer doesn't have dexterity issues, then a small-headed and a soft bristle manual toothbrush is good. The dexterity issue patients who don't have such a compromised situation where they require a carer, but they are doing it themselves, but they have issues with the strength in their hands. In those conditions, power toothbrush are recommended over manual. Now, did you get your answer? I forgot to see the name, but I hope you got your answer. Leo. Leo, is your doubt answered now? So if in the entire history, you are suggesting your patient to handle the oral care and the oral hygiene practices, and you think they're limited dexterity, go ahead, choose power toothbrushes over the manual one. But if the carer or the nurses in the residential care are looking after them and doing their toothbrushing, then a small-headed, soft toothbrush manual is good enough. Make sense? Because ultimately it's the technique that applies, right? So in addition, a combination of toothbrushing with dental flossing, mouth rinsing, and topical application of fluoride is suggested for these patients for better management of their oral hygiene. Now, how will you care for the dry mouth? Unless the patient is NBM or on fluid restriction, then number one, as per the therapeutic guidelines also, what is the recommended advice? Number one, the oral hygiene, the oral hydration, right? Yes, drink sips of water, keep hydrated. So frequent sips of water help keep the mouth moist. Apply dry mouth moisturizing gels or sprays, lubricate the mouth, then saliva substitutes, artificial saliva, including saliva substitutes and stimulants may be prescribed, in particular for patients with severe dry mouth. Chewing sugar-free gum can help stimulate salivary flow. It is important to restrict the sugar intake, alcohol intake, caffeine intake. Of course, that goes for a normal patient. Such medically compromised would not be taking alcohol or caffeine. But restrict the sugar intake. Check regularly for oral thrush, especially in patients with xerostomia, as they are at high risk of developing caries and candidiasis, right? So oral mucositis management would be by applying local analgesic gel, because we read that number one factor is the soreness and pain, right? So then you apply the analgesic gels, give them mouthwashes, bland rinses like sterile water, normal saline, moisturizing gels. It can help them reduce the pain and discomfort. In severe cases, you may require NSAIDs, even opioids, sometimes depending upon the severity of pain. We have read in therapeutic guidelines, management of pain, right? So mild to moderate pain, we are mostly relying on paracetamol. Moderate pain, we are relying on NSAID and paracetamol combination, and then eliminating the NSAID as the pain subsides and the cause is addressed. And in the severe pains, we are bringing in the opioids. Is that correct? Oxycodone, absolutely correct, Saida. But did I say the management correct? The mild, moderate, and severe as per the TG, that's how you progress. And that's why as a dentist, for any particular pain management due to the oral causes, that should be your criteria to select the painkillers based on the history. Would you be able to apply that to root canal pains, to your other dental causes pain, and even your oral mucositis pains? Does that make sense? So that's called extending your knowledge to various scenarios based on one concept. Am I correct when I say that? Would you be able to do that in exams? Extend your knowledge to other SBQs based on one key concept. That is why I make sure I always ask you to memorize the regimes, and next week onwards in the live classes on our Study Buddies group, I'm going to ask you every single possible regime on TG, right? That's what we're going to do. Make you practice that. All right. So then the oral candidiasis, how we work on that. In view of lower risk of side effects and drug interactions, topical antifungal agents like nystatin and clotrimazole, we've read that in TG as well, therapeutic guidelines. Nystatin and clotrimazole. So efficacy of these topical agents seem to be inconsistent, and therefore systemic agents like fluconazole sometimes may also be required based on the clinical observations, how the condition is responding to the topical therapy. But mostly with extensive immune suppression and persistent candidiasis, systemic therapy would be going hand in hand with the topical one. Patients who are wearing removable dentures are advised to remove them before starting antifungal treatment and to soak them overnight in antifungal solutions and peroxide and enzyme-based or sodium bicarbonate-based solutions. RPDs, it's a very, very important question ADC is asking every time. Which solution is RPD not soaked in? We did it in the live class last week as well, so I know my students would know the answer quickly. Which solution are RPDs, metal-based RPDs, not to be put in immediately? Hypo, absolutely correct. Bhumi, Marcella, Simran, happy to see the answers. Hypo leads to corrosion of the metal component of the RPD. So we don't soak in that, right? So what do we soak in that? Then we soak in peroxide-based solutions, enzyme-based solutions, or sodium bicarb-based solutions, right? Now, denture care for patients wearing dentures. So you will clean the dentures with commercial denture paste or soap, soak them in the clean water overnight. And now the TG's latest guidelines is sometimes you can soak them in dry air. No need to soak them in the water because the shrinkage that component was considered before is clinically minimal, right? Do you all agree with that? We've learned that concept as well. Yes. Osteoradionecrosis is a serious complication of radiotherapy to the head and neck region where an area of exposed, devitalized, irradiated bone fails to heal over a period of 3 to 6 months in the absence of a local neoplastic disease. So for the ORN, the diagnosis, the presence of a radiotherapy history is utmost important. If that's not there and an osteonecrosis is setting in, then we look for the medicated reason, right? So therefore, patients who are about to undergo radiotherapy are required to have a comprehensive dental checkup and remove any grossly carious teeth, as well as loose and mobile teeth to minimize the risk of osteoradionecrosis. So question asked, how will you manage the patients? And how will you prevent ORN? Before they start the therapy, remove any of their grossly carious teeth, loose teeth, mobile teeth to prevent the risk of ORN. Would you remember that? Yes, absolutely. Better to at least 3 to 4 weeks before extract them, right? Now, good oral hygiene practices should be instilled in them, therefore, starting cancer treatment and continued both during and after treatment. So, the good oral hygiene still should be managed and health promotion should continue for them before starting the treatment and during the course of the treatment and after the treatment as well. Now, these patients can also have dental caries and perio disease. How will you manage them? So oral complications like dry mouth and saliva gland function can render these group of patients at a high risk of developing caries and perio disease because high buffering capacity of saliva protects from caries, right? And your periodontal disease because it flushes out the plaque. Plaque is the also most leading cause for both perio disease and the dental caries. Is that correct? So therefore, the management and the advices that you would give to patients like these would be to limit their sugar intake. High fluoride toothpaste. High fluoride toothpaste, what strength do we recommend for high caries risk? 1,000, 1,500, 5,000? Absolutely correct. The 5,000 strength toothpaste is coming their way. Apply the varnish. Use 0.2% chlorhexidine gluconate mouthwash. What is the period for which you can recommend the chlorhexidine mouthwash? What is the limit? 2 weeks? Yes. It will help reduce their caries and perio risk respectively. Is that correct? Makes sense? So how is the multidisciplinary approach? Well, oral and potential systemic complications like aspiration pneumonia, malnutrition can require these group of patients and the dentist to collaborate with the other health professionals, which would include dietitians, speech pathologists, medical practitioners, medical specialists, and carers of these patients. Now, very importantly, have you been noticing the trend in the questions that are getting asked? Patient has this particular problem, who will you ask? So the options are given. Talk to their dietitian to alter their diet. Reach out to the medical practitioners, reach out or call the translators when there is a language problem, or a speech pathologist when your patient has problem. So have you been already not noticing all these questions which involve the other disciplines? Because ADC wants you to know when does your expertise end and when a teamwork is required. They don't want you to be approaching everything by yourself, and know that what are your areas of concern and when you require the team approach and other disciplines and other specialists involved to give your patient a wholesome management. That's the approach of ADC. Isn't that correct? Have you been noticing questions like that? Like a sick patient who's in residential care, the wife visits and the carers are required. Those are the certain cases where you would be using them, right? Then there are patients of a woman, teeth are getting lost, calcium deficiencies, collaborate dietitian. Am I correct? Is it ringing some bells with the advanced file questions? Yes. So we don't need to go on and tell them take calcium rich diet and all that if you think there are nutritional deficiencies. ADC is giving you options like that. Include dietitians. What is that for? For you to know and understand that the collaboration is required in the overall management of patients. That's the purpose of including multidisciplinary questions in this exam, right? They're not just testing your general dentist skills or your just perio textbook skills or prosto skills. They're giving you the clinical situations where you would be thinking as a overall healthcare professional and not just your technical dental concepts. Did I make complete sense when I say that? For you to keep that approach in exam when you're answering these questions. So dental practitioners have a key role to play in referring these patients for further management where appropriate. This in turn would help in alleviating the general health risk associated with such complications and improving the quality of life of these patients. Is that correct? So how will I summarize it? Patients who are NBM or feeding on tubes or undergoing chemotherapy, radiotherapy, or those in palliative care, they are at a higher risk of developing oral complications which can jeopardize their further general as well as oral health. Xerostomia, mucositis, and candidiasis are one of those major complications. The presentations of these three conditions is dysphagia, difficulty in speaking, pain, soreness, burning sensation in the mouth, thick stringy saliva, dry cracked lips, taste changes, and difficulty in wearing dentures. These group of patients can develop serious complications. Question can ask you, this is a group of a patient, this is their systemic cause, these are the oral manifestations. Another question can come up, what do you think can be, if you don't manage it timely, the life-threatening implication of these conditions? What is the answer? Malnutrition and aspirational pneumonia. Would you remember these two severe life-threatening conditions coming from these oral manifestations of medically compromised patients? Absolutely correct. Given the vulnerability for the further deterioration, it is essential to instill and maintain good oral hygiene practices so you know what kind of toothbrush and where, in what situation. Everyone knows now the strength of fluoride, the rinsing versus spitting method. Then, in order to minimize the general health risk and to improve the quality of life, these patients, dental practitioners have a responsibility to collaborate with other health professionals as well as carers of the patients and to refer them for further management. Does that make complete sense? Okay. Before I take the doubts now, I have one very important announcement, guys who are here in the class. We are going to conduct a free mock exam for everyone, including 50 questions. It would be timed for 90 minutes. So it's first time ever in the last 8 years. Every time I get this request to have a free mock, sell my mocks, never have been I selling my mocks. It's only for my course. So my course student, they get a full 4 paper test. We are releasing it today, actually, as I said. So those who are here, my students, you know what to do after this, or probably you've taken it and I'm waiting for you to send me scores together. So 4 paper mock exam, we are doing it in course, but for general, public request. I'm releasing my first mock for public, which is 50 question, but still no, extremely hard questions, extremely ADC level, extremely Winsport level, I would say that, because if you have been doing our weekly quizzes, a daily quiz series on our group, you know that I don't just randomly throw and copy paste old file questions. You know it. If you are solving my questions, you know that I will go take pain and find a question which is relevant, which stimulates your nerves and stimulates your thinking, challenges you, and gives you and throws you a concept in a different light. So that is my purpose. I would not waste my time just to throw random copy pasted questions from the files, but rather to give you questions that really challenge you. So similarly, I've hand curated and picked those questions in the mock exam as well. The dates would be announced soon, so it is going to be in coming days also. Keep a check on our group, and that's when it would be timed. It would be like a real time timed 50 question test. And post that, I will keep one class. It would be a free discussion class. I'll give you explanation for each question, and you could ask me your doubts as well there. So we will have a free discussion also. And discussion, I will also keep a day or two after, not later than that. Yeah. So much gratitude to you. Much thank you to you for helping me and supporting me and the audience that I get in the live class. So it has given me courage and motivation to bring this mock. So I hope you took away a lot from this session, and I think Leo had a question. I want to address that. Leo, if you could place it again. Overextend or underextended denture flap? Overextended, Leo. Answer is overextended with a constant rubbing and irritation. Underextended would be there would be lack of stability, there would be no retention. So Leo, I hope you got your answer. Overextended epulis fissuratum and underextended is a lack of retention, right? So thank you so much, guys. I hope there was so much to learn. There is always so much to learn. I learn with you guys every time I, do an article with my students, and I just end up learning so much. And also, those who are new here, if you want to join us for the September course, we are starting on April 8th, but I'm giving the 8 weeks access to the website at no extra cost, so you can join this. JS, I don't know what you wrote unrelated to this topic. Jules, I missed your... Yeah, Jules, go ahead. I will be posting this article on the Facebook group. Please watch there, Huma. Jules, you go ahead and ask me what you were intending to. Sorry if I'm missing the doubts there. So it is 2 weeks as per the latest IADT guidelines. As per the latest trauma guidelines, it is 2 weeks. For the fractures and alveolar fractures, it goes more than 4 weeks, right? Periapical, periodontitis, and periapical abscess. Wonderful question. Very simple answer. Basically, periapical, when it involves the surrounding the area of the root, right? Periapical periodontitis is a radiographic diagnosis. It can be with the bone loss. It can be with the PDL dilation, right? A radiolucency is there. It's periapical periodontitis because the periodontal surface is involved. Periapical abscess is a clinical diagnosis. How? An abscess would mean soft tissue involvement, Jules. So when you're giving a radiograph and there is radiolucency, but there is not a soft tissue swelling, then it is a periapical periodontitis. But when there is a periapical radiolucency associated with clinical finding of a soft tissue bump, pus accumulated in that is a periapical abscess. So when it's just bone involved, Jules, then it would be periapical periodontitis. When the soft tissue also gets involved, then your diagnosis would be periapical abscess. Both are associated with non-vital tooth only mostly, right? You know that, but it can come from persistent trauma from occlusion also, which ultimately would affect the vitality of the tooth. Both periapical perio and periapical abscess are coming from non-vital tooth infected pulp. Periapical periodontitis is a radiographic involvement only, bone involvement only, PDL involvement only, whereas the abscess is the soft tissue involvement when the bump is seen. Did I make sense? I hope your doubt is sorted before I take more. Perfect. Docs can be given in children less than 8, but not tetracycline. So see, as per TG, now the latest one you've read, Leo, right? You can give, basically. It's saying even in early you're giving. But a lot of practitioners in practice, are they giving? Still no. Shikha, you can send me the screenshot if you've seen that somewhere, but just follow the latest IADT guidelines. I would not even recommend you to go anywhere else and do that because there are so many chronological references available, Shikha, for Evulsion, like years ago. And then I would say just stick to the latest guidelines. Even endo guidelines related to Evul's tooth keeps changing, right? Doing extraoral endo, not doing it now, then doing endo within 7 weeks or 7 days, 7 to 10 days, then earlier used to wait. So all these guidelines keep changing, but follow the latest IADT guidelines, hands down. If you look somewhere else, you don't know chronologically where it was from, right? Even a textbook, I would not recommend, just follow the IADT guidelines and you will always land those questions correctly. Yes, when the carers keep changing, Vijay, then you have to conduct an entire education presentation for that center to educate each carer so that even if when they're shifting turns, when they come to that patient, they are educated about giving the oral care to such patients. I hope I answered your question correctly, Vijay. It is about the old age care where the wife was sick or the husband was sick. There are both the variations. Yes? With the short dentate and the implant condition, right? Yes. It is absolutely hand excavation, GIC. Shafi, we have done the University of Adelaide article in our course. I have shown my students the entire article with the same scenario, nursing home patient. Husband was, in that case, wife was sick, husband was carer. In the ADC exam, a husband was sick and the wife was coming. And we did all those reference by reference, but I'm giving you the answer now. GIC ART is the method for them, for the dementia patients. They get triggered by the loud noises, right? And it's easier on them, the ART techniques. It is a recommendation by University of Adelaide. I can vouch for that. Well, we are doing, Arpita, the domestic violence articles also. So we are following everything by references as suggested by the laws. So if the patient doesn't stand for themselves, you will have to involve authorities. Namrita, check out the latest 3rd edition, the latest stand of TG on docs, and then you can message me. You have my number. If you are on the dental education group, message me on my WhatsApp, okay? And we can discuss it there. All right, guys, I think we're done for today and I had lovely time. I hope to see you soon and you guys register for the free mock exam. Please keep to check on my group, on the Facebook group, and you'll find more details about where to find the information regarding the free mock. And then we'll take it from there. A day or two after, I'll also announce when is the free discussion of that mock. So we'll have that discussion as well. Towards the end of Feb, that's the plan basically, close to between 20th to 21st Feb to 28th Feb, between that. MTA is most superior, if you're asking preference. Thank you so much. Thank you, guys. I'll see you next month. Exam would be on my website, Jyoti. It would not be on WhatsApp. So the mock exam would be released on our website. We will give you the registration details and everything when it happens, right? Just keep a checkout on the group and my team will be posting how to register for the exam. Thank you. And I'll take a poll again next month. We'll decide on a topic. Even if you take your part 1 exam and you still want to attend those classes, because I don't think I'm going to stop, even it will help you for your part 2 preparation. So always stay positive. You will clear the exam. Come and join me because it might help you for your OSCEs. All right. Thank you. Yes, absolutely no contraindication to MTA other than that it takes a little bit longer to set. That's the only drawback. Thank you, Leo. I try to clear instantly whatever I can remember from the top of my head. I'm just getting so used to these doubts. Like I know the questions. You ask me a question, I'll know which page, which file, which exam it came for. So that's the kind of conditioning it's getting. I'm used to, but some things I might even not know immediately. And for that, I would always ask you to check back with me. I also have to sometimes cross-check with the reference. So much to remember, so much to produce, but still I try my best. And I'll see you guys next month. Help me deciding the concept and the topic that we'll discuss. Feel free to join me for the September course if you're looking for that. Otherwise, I'll see you every month anyways. And see you for the mock exam. Part 2 prep I'm not giving, but I can definitely tell you my monthly sessions will help you with the part 2 preparation also. I can assure you that. So many of my students have been telling me to start giving that, but I have no bandwidth to do the part 2. But with these, I think monthly sessions, I intend to cover both part 1 and part 2 topics, like which help you with the both exams. So that's the intention. All right. Good night. See you. Thank you so much. Have a very fabulous weekend and study well. Bye-bye. Thank you. Good night.